So neurodevelopmental, we've covered neuro. Developmental, changes over time. Things look different at different ages. And specifically neurodevelopmental, we know that the brain looks different at different ages. One of the common findings in very young children with autism is somewhat larger heads than we see in typically developing kids. Now, this isn't true in every case, but on average, we often see larger heads. And studies have shown that early in life, the brains of children who later are diagnosed with autism tend to have an overgrowth of certain areas of the brain. It grows much faster, and the head, in turn, grows faster. There is a phenomenon that's called pruning that happens early in our lives. We're born with so many different connections and neurons, but those that aren't going to be useful get pruned. So they go away to make room for other things to develop. And one theory is that the pruning aspect in individuals with autism doesn't work as well as in typically developing individuals. So there are a whole lot of things there that aren't taken out, that aren't necessarily useful in day-to-day life, but in some situations may be. Now back to the definition. Neurodevelopmental condition characterized by deficits in social communication and interaction, restricted repetitive patterns of behavior, interests, activities. Now in the DSM-5, which is the manual that defines autism and many other disorders, the deficits in social communication and the restricted repetitive patterns of behavior are the first two criteria for diagnosing. So criteria A and B, and I'll refer to them as the major criteria. We also have that the symptoms must be present early on, and they cause impairment in functioning. But I'm going to go into more detail about these major criteria. So deficits in social communication and interaction, manifested by all three of these things, either currently or it can be by history, may have happened in the past. So first, and I'm going to go through each individually, deficits in social emotional reciprocity. So what is that? Abnormal social approach, not knowing how to begin an interaction. Failure of normal back and forth conversation in those individuals who converse. So trouble starting, ending conversations, not picking up on some of the conversational cues, having trouble talking about topics other than what I want to talk about, talking on in a monologue, which you're hearing now. Reduced sharing of interests, emotions, affect. So not showing pride, hey, look what I did. If I see something really cool, I'm just looking at it. I'm not pointing it out to someone else. I may not notice when somebody else is hurt or upset. Somebody's crying and I'm just covering my ears because it's loud noise. Or failure to initiate, respond to social interactions. So my child doesn't respond to his name, I often hear. Appearing deaf, not really noticing that other people are there. Even I've had some kids just climb over me during appointments. When young, not showing much interest in social games like peekaboo, things like that. Next, deficits in nonverbal communicative behaviors. So poorly integrated verbal and nonverbal communication. Again, this is more specific for individuals who are verbal. But in general, decreased, unusual, or absent nonverbal communication. unusual facial expressions or not having many facial expressions, abnormal eye contact. Classically, many people, when they think of autism, think of someone who does not make eye contact. And that can certainly be the case. But abnormalities in eye contact are not limited to not making eye contact. Some individuals, especially as they get older, if they're told you need to look people in the eye, they may do it, but they may keep that gaze for a prolonged period. Usually when you're talking with someone, you make eye contact for a few seconds and then you look away. If you're talking to someone who does not look away, you may feel uncomfortable and not quite know why it is you feel uncomfortable. Deficits in understanding and use of gestures, so not pointing, nodding head, shaking head, etc. Abnormalities in body language, trouble knowing how close to stand to somebody. Unusual tone or voice quality. So having a very monotone voice, always sounding the same and not being very robotic and all that. Or having a very lilting voice, so going up and down. And third, deficits in developing, maintaining, and understanding relationships. So trouble adjusting behavior to different social contexts. Most people, most adults know you behave differently when you're at work than you do when you're at home, than you do when you're at a wedding, than you do when you're at a funeral. So making those adjustments, and even children, typically developing children will behave differently in different contexts, but realizing that you need to adjust. Trouble sharing imaginative play. If we do have imaginative play, I'm dictating what it is, as opposed to playing off each other during imaginative play. Trouble making friends. Now, in some cases, this is because of a lack of interest in peers, but sometimes it's because I just don't get the rules. I don't know what am I supposed to do to make friends with somebody? Why doesn't this person like me? I like them. Sometimes we'll see kids who have relationships only with those much older or younger. So a child who relates great to adults, but not so much to other kids. Relationships based primarily on special interests. Trouble interacting in groups and following cooperative rules. Sometimes when I talk with families about the possibility of sports for kids with autism, I'll caution against your traditional team sports. So things like soccer, baseball might not work so well with a kiddo who's on the spectrum. Now, what might work better, and I do suggest socializing however you can, but something where you aren't depending on other people and they aren't depending on you, but you're still interacting. So swimming, being on a swim team, gymnastics, dance, martial arts. Now, the next major criterion is restricted, repetitive patterns of behavior, interests, or activities. And for this, you don't have to have all 4 of these, but you need to have at least 2 of them. Again, either currently or in the past. And I'll go through each of those in more detail. So first, stereotyped or repetitive motor movements, use of objects or speech. So simple motor stereotypies. That's things like hand flapping, odd hand postures, or other hand movements. On this slide, the child who's wearing the red, you see the hand posturing, holding the hand at an unusual angle, spinning, rocking for long periods, lining up toys, pretend play that's repetitive or stereotypic, so I'm doing it the same way every time. Or my pretend play might just be reenacting what I have seen on my favorite cartoon. Echolalia, I think many of us may be familiar with this, repeating what others say. And when we think of echolalia, we often think of immediate echolalia. So I say something, you get it right afterwards. But there can also be delayed echolalia. So a child uses a catchphrase that they've learned, again, from a cartoon, or they can quote an entire scene from their favorite movie. Echopraxia, imitating actions of others. This can be a little bit disturbing. I've had it happen during appointments where I would cross and uncross my legs and not realize how much I was doing it until I saw the child across from me doing the same thing. Sometimes individuals with autism will use words or phrases that have special meaning only to them. And sometimes they'll be overly formal, pedantic, like a little professor. So talking on and on. Think about Sheldon from The Big Bang Theory, if you're familiar with that. Next, insistence on sameness, inflexible adherence to routines, or ritualized patterns of behavior. So being extremely upset with small changes. I pick the child up from school and wait, this is not the way that we go home, and they have a meltdown. Restricted food preferences, only eating a handful of foods. Having trouble transitioning from one activity to another. Wanting to perform certain activities in an exact order. So mommy has to put me in the car first, then big brother gets in, then daddy gets mommy's door, and then daddy gets in. Unusual pretend play, not having a lot of acting out scenarios with toys, or using toys in a concrete manner. I have dollhouse furniture, but I'm not having my dolls sit there and interact. I'm just rearranging it and making my pretty interior decorations, but still not your traditional pretend play. Now, highly restricted, fixated interests that are abnormal in intensity or focus. So strong attachment to or preoccupation with unusual objects. Strings, ballpoint pens, straws. I recently had a child come in carrying a spatula. That was his thing. Excessively circumscribed or perseverative interest, strong focus on particular topics to the exclusion of others. This is all I want to talk about. This is what I'm interested in. Trouble letting go of these special topics or certain activities. A child is so engrossed in doing whatever it is that they use the bathroom on themselves, even though they're completely toilet trained. Now, I did include my little Frozen picture, both for the trouble letting go to help you remember that, but also because over the past few years, I've seen several kids whose special interest was Frozen. Elsa, Anna. We can see interest in topics that are unusual. Fire extinguishers is one that I've seen, sprinkler systems, astrophysics. In our part of the state here in Mobile, sometimes weather is a special interest. An excellent memory for details of special interest. So somebody who can come in and tell me the name of every one of these dinosaurs and what they eat or ate. And finally, hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. This is your sensory processing issues. Apparent indifference to pain or temperature. The child who gets hurt and we don't even know that the leg is broken until 2 days later, or we've got a raging ear infection. We fall down, we get right back up and go on. Adverse responses to sounds, textures. Whenever I hear a blender, I cover my ears. Public restrooms can be bad for a lot of kids. The flushing, the air dryers. Interest in sensory qualities of objects, whichever sense. Excessive sniffing is one. I've had more than one child during an appointment just come up and sniff my arm. Visual fascination with lights or movement, gazing at overhead lights, ceiling fans, etc. Closely examining objects. Think about wheels, spinning wheels, watching that. Flicking fingers in front of the eyes or beside the eyes. Now, there are some red flags that we can see very early in life. Some of these things that I've described are more applicable to older kids, but very early in life, we can see many of the signs. So things that should alert you to the possibility of autism. They don't necessarily mean that's what it is, but they should prompt you to explore further. If a child doesn't babble or coo by 12 months of age, if they don't gesture, pointing or waving by 12 months, and I'll say here, most children will point to ask for something, point at something they want by 12 months. They will point to show something to someone else by 15 to 18 months. Another red flag, not saying single words by 16 months, not using two-word phrases by 2 years, and loss of language or social skills at any age. Now, what is autism? It is a disorder. It does cause problems in functioning. But while there are a lot of challenges, there are also many strengths. So a child with autism might not make friends easily, but those friends that are made, this child is very loyal. They have trouble figuring out social rules, and may need explicit instruction. But in some cases, they can think through the social rules. Okay, this is what I'm seeing other people do in this situation, so maybe I should do this in a similar situation. They can find it hard to fit in, but good at being individuals, not easily swayed by peer pressure. They may have trouble following conversations, but if you want the facts about something in particular, you can get it. Especially if it's that one special topic that they can talk about at length. Not great at small talk, not your cocktail party guests. They may use unique expressions, words that mean something special to them, but when other people use figures of speech, non-literal speech, they may have trouble understanding. So jokes might not make sense. Figures of speech might not make sense. Individuals with autism tend to be very honest, speak their mind, which can be great, but can also hurt people's feelings. As far as learning, we have a different way of thinking. We can have some very unique ideas, but sometimes practical solutions, troubleshooting, is not the easiest thing. Interests, we talked about special interests. We have a few very deep interests we know a lot about, but there are many things that we don't know very much about that other people might know about. Individuals with autism tend to be good at working independently, but your team project is not a great fit. If they're interested, they can stay focused on a project until that project is done. If they're not, they might have more trouble. But multitasking can be a little bit more of a challenge. Now, one thing I often get asked when I'm talking about a diagnosis of autism is, what level is my child? And I will explain severity levels, but I usually tell families that the ages of children that I'm seeing, I don't feel like severity levels are very useful. So the severity levels are defined by the amount of support that an individual requires. Children, young children, require substantial support in general. We also know, and the DSM-5 specifically says, that an individual can change over time from one level to another and may function at a different level in different situations and settings. The DSM also specifies that when you are giving severity levels, you should separately rate the social communication and interaction, and then separately rate the restricted repetitive patterns of behavior, interests, activities. So yes, I could theoretically say a level, but it's not going to stay the same. We hope it's not going to stay the same for a child. If a child is very severe right now, our goal is to make sure that we have the right interventions in place, that we can get that level better. And in some cases, in some situations, we'll see an individual functioning below a level 1. So not really having any deficits, not needing extra support in certain situations. Now, what causes autism? Often we don't know. We do know there are a lot of different things that can cause it, but in most cases, with most individuals, we are not able to pinpoint one specific thing at this point in time. We do know that autism is biologically based, it's highly heritable, and multiple genes seem to be involved. About 10% of the cases are associated with a medical condition or syndrome. And we know that environmental factors may modulate pre-existing genetic factors. So genetics, we've got this from the time the egg meets the sperm. This is what's there. Environment, even starting prenatally, we have environmental effects on the brain. And both of these can impact, affect, cause autism. So thinking about risk factors, if you have a relative with autism spectrum disorder, you're at higher risk. There are certain genetic conditions that we know specifically give a higher risk of autism: Fragile X syndrome, tuberous sclerosis, and Down syndrome. We know that prenatal exposure to certain drugs, including drugs that are used to treat seizures, can be a risk factor. So thinking about the genetics of autism, monozygotic or identical twins, if one of them has autism spectrum disorder, there's a 90% chance that the other twin will also be diagnosed with autism spectrum disorder. So that tells us that, yeah, there is strong genetics here. dizygotic twins, that's non-identical twins, if one twin has autism, the other twin is still going to have an increased risk, but that increased risk is the same as with any sibling. We know that various genes on multiple chromosomes are associated with autism. And I will say that over time, I think we will identify more specific genes that are involved with autism. The field of genetics is really exploding right now. And when I order genetic testing, I will often get results that say they're abnormal, but it's of, quote, unknown clinical significance, meaning we don't have enough data yet to know if this is something that causes autism or not. Now, like I said before, you've got the genetics going for you, but there are other things that can modulate those genetic factors. So teratogens, those are things, medications, etc., that can cause different harmful effects to a fetus. Maternal illness, we know, newborn encephalopathy, so having early damage to the brain can have a role in causing autism. Now, one thing that does not is vaccines. The one study that linked the MMR vaccine with autism was retracted in 2010. However, the idea of vaccines causing autism has lingered. And part of that may be because of the time that kiddos get administered the MMR vaccine, which is between 1 and 2 years of age. That corresponds with the age at which many children with autism will have a regression in language and other skills, again, between 1 and 2 years of age. That being said, we know that that regression happens, we've seen it, in children who are not vaccinated, as well as those who are vaccinated. So there's a relationship there. It happens at the same time, but it's not a cause. And if you need more information, www.immunize.org. Now, so we're seeing all these things that go along with autism. Okay, I buy that. Well, could it be something else? Simple answer is yes. Now we know for autism, you have to have both deficits in social communication and social interaction and restricted or repetitive behavior, interests, activities. If you just have one or the other, you may have an isolated vision impairment, hearing impairment, language delay, a social or pragmatic communication disorder, anxiety, obsessive compulsive disorder, sensory processing delay, or a number of other things. That's why we want to make sure we've got both going on, or in the past. Now, when we're thinking about autism, we do have to think about, okay, what else could it be? So we think through these different differential diagnoses, is the medical term that we use. And in many cases, it may be one or the other, but in some cases, it can be both. Having one thing doesn't mean you can't have something else. Having a cold doesn't mean you can't also have allergies going on. So some of the things that we want to look at and make sure, if they're present, that they are not the exclusive cause. Intellectual disability. So individuals with intellectual disability often have features that are common to autism, stereotype movements, rocking back and forth. And it can be difficult to differentiate. But in an individual who has intellectual disability but does not have autism, our social and communication skills should be at levels expected for overall development. So in other words, if I am seeing a child 8 years old, but whose cognitive level is equivalent to that of a 4-year-old, I would expect our social and communication skills to be at the level of a 4-year-old, which we still have some strong social drive at 4 years. Next, isolated language disorders. Usually with that, your social skills are relatively preserved, and you aren't going to see the restricted interest repetitive behaviors that you would see with autism spectrum disorder. Tic disorders, Tourette's, motor mannerisms, the stereotypies are common. And in many cases, we also have intellectual disability, but social skills are relatively preserved. Depression, usually depression is going to not have onset until a later age. So we will have seen some typical development. We won't have those early changes. But individuals, even children who can get depression, will have social withdrawal, limited interest in what's going on. But they will have had relatively normal functioning before the symptoms came on. And in most cases, they don't have developmental delays, but that can be present. And then anxiety disorder, extreme social withdrawal. We can see sleep problems, agitation and worry interfering with social and academic functioning. But individuals who have anxiety without autism will often have normal relationships with their parents and in situations where they feel comfortable and safe. Obsessive compulsive disorder, the restricted interest, repetitive behaviors are right up there. But with just obsessive compulsive disorder, the social and communication skills should be unimpaired. Reactive attachment disorder, you may or may not be familiar with this. Reactive attachment disorder has been studied a lot with children in orphanages in Eastern Europe in the past. It's seen in children in foster care and others who have had unstable early social environments. It is a result of a child not attaching to a primary caregiver. It can look a whole lot like autism spectrum disorder. We've got the social deficits, we can have repetitive stereotype behaviors, a number of other things. Differentiated by a history of severe neglect. And if you have reactive attachment disorder but do not have autism, the social deficit should get better in a stable environment. That being said, sometimes we have both, and that can be tricky to diagnose. ADHD. Children with ADHD, just because they are so active, so impulsive, that may cause them to be socially isolated from other children. They may have difficulty focusing on tasks, but be able to hyper-focus on certain things. So that sticky attention I talked about before. But usually they can display typical social and communicative behaviors in the right setting. Oppositional defiant disorder, conduct disorder, these are characterized by noncompliance, saying no, not doing what you want, physical aggression in many cases. Now with ODD and CD, those children tend to be aware of the impact that their behaviors are having on other people. With autism, not so much in many cases. And hearing impairment. So I always advise my trainees, make sure the child can hear and see. um, a child who is hearing impaired may not respond to their name. They may have a delay in speech language, but they will use other means to communicate if they do not also have autism spectrum disorder. So gestures, facial expressions, um, they will show a social drive. They won't be isolating themselves. With vision impairment, impaired visually dependent nonverbal communication. So if I can't see, I'm not going to point. There's nothing to point to. If I can't see, I'm not nodding my head, shaking my head, etc. Um, many children with vision impairment have certain stereotype behaviors. So rocking, head swaying, pressing the eyes are all fairly common. Um, their early imitative play and make-believe play may be compromised, may be delayed because they aren't seeing someone visually modeling, okay, this is how I do this. This is how I make believe. And they may have restricted interest just because of lack of exposure to a range of things. Um, that being said, they do seek to share information, experiences, show pride. Um, they learn to play appropriately with certain objects. I can cuddle and rock a baby doll. I can roll a car and make vroom vroom noises. And as long as they feel safe and they know what's going on, relatively easily engaged in a range of activities. Now we know there are all these things that it could be instead or it could be in addition. We do know that there are certain things that occur more commonly in individuals with autism. So individuals with autism are more likely to have intellectual disability. This is not saying that every individual with autism has intellectual disability. Um, there are geniuses, again, think of Sheldon with the autism spectrum disorder, but it is seen more commonly than in the general population. We often see feeding issues, problems with toileting and sleep. We can see aggression, constipation and other gastrointestinal problems. Seizures are more common. ADHD, anxiety disorders, tics, obsessive compulsive disorder, language delays, problems with coordination, and of course, sensory processing issues. Okay, so why do we want to label kids so young? I'm going to start at the end of this graph and work my way backwards. We want to label kids so young because we want to decrease long-term costs to society. We want to decrease the long-term negative impacts on the individual and the family. How do we do that? We do that by improving the individual's functioning. Help them learn, okay, how do I do this, that, the other thing? How do we improve functioning? We do it through interventions. The earlier, the better. Lots of research has shown us that early interventions of various sorts improve long-term outcomes. We get to our interventions through, one step back, evaluation. That being said, I want to shout it from the mountaintops. You do not have to have a diagnosis of autism before you get many interventions. You can start speech language therapy if you have a language delay. You don't have to have a diagnosis of autism. You can start occupational therapy if you have a fine motor delay, and so on. And we get to evaluation through regular surveillance and screening. And we'll come back to that in a little bit. So I mentioned early intervention. So early intervention with a capital E and a capital I is for kids in the US below 3 years of age, and there's been a lot of research on that. But there's also been research worldwide on different programs targeting children below 3 to 5 years of age. A number of positive outcomes have been seen in these children that participate in programs as opposed to those who do not. And these are not just children with autism, but all sorts of developmental delays and other issues. So less need for remedial assistance, less school failure, less disruptive behavior in the classroom, better parent-child relationships. Down the road, less risk of using drugs, fewer emergency room visits, improved family income, increased employment rates, and decreased welfare dependence, decreased teen pregnancies, decreased child abuse, better peer relationships, better able to support oneself and find help where it's needed. Bear with me, I'm having trouble paging down again. There we go. Okay. All right. So I mentioned developmental surveillance and screening, which leads to evaluation, which leads to yada, yada, yada. The American Academy of Pediatrics has recommendations for developmental screening and general developmental screening for all kinds of developmental delays is recommended at 9 months, at 18 months, and at 24 or 30 months, plus any time that concerns are raised. So raised by the family or raised by the physician. Autism-specific screening is recommended at 18 months of age and 24 months of age. And some of you may be familiar with the MCHAT here, the Modified Checklist for Autism in Toddlers. It's a 20-question yes/no checklist filled out by families that can help us say, yeah, we probably have a high risk, or no, we probably don't have much risk for autism. And that can lead us towards evaluations. Now, we also want to label kids so young because we know it's a big thing, and we want to get as many of these kids as possible into the right interventions. Now, there are different figures out there, but this is from the CDC. They have an ongoing disabilities monitoring. And in 2018, 1 in 44 8-year-old children were identified with autism. Now, this would mean that in elementary school, 1 kid in every 1 or 2 classrooms has autism. So being aware, knowing what to do, having the right interventions in place. And we also know that prevalence has gone up across the board in every race and ethnicity. So yeah, that's great and all. We do want to label kids young. We want to get that diagnosis so we can get the right interventions in place. So why does it take so long to get a diagnosis? Lots of reasons. Not the least of which is the increasing prevalence. The 1 in 44, that is a lot of folks to get diagnosed. There's a limited number of specialists. Developmental behavioral pediatricians are few and far between. There are other specialists who diagnose as well, but again, there are not a whole lot out there. There aren't as many as are needed to do an in-depth specialty evaluation. There's not great insurance reimbursement for some of the evaluations that are done. They can be very lengthy and in-depth, and they aren't reimbursed like, for example, a surgery would be or a biopsy. In many cases, the diagnosis isn't straightforward. So you want to gather as much information as possible before saying yes or no. And although we're trying to get more primary care physicians comfortable, many are not comfortable diagnosing. And in complicated cases, that's understandable. But if we can get what we call our slam dunk diagnoses, make sure that we have ruled in and ruled out everything we need to, a primary care physician absolutely can make a diagnosis. Okay, so again, back to our definition: neurodevelopmental condition, deficits in social communication and interaction, restricted repetitive behavior interest activities, symptoms in early development, impairment in functioning, and not better explained by another condition such as intellectual disability. So we have to have an extensive evaluation to make sure that we aren't misdiagnosing. And we know that there is a wide range of what we see with autism. Autism spectrum disorder. If you've seen one kid with autism, you've seen one kid with autism. The variability of expression of symptoms of ASD makes the diagnosis difficult. Multiple comorbidities confound the issue as well. And because we want to make sure we've got the right diagnosis, so we get the right interventions, a diagnostic evaluation should include evaluations of hearing and vision. If hearing or vision is interfering with functioning, you want to know that. You want to take that into account. Cognitive developmental evaluation. Where is the kid functioning cognitively? Evaluation of adaptive behavior or daily living skills. We know that individuals with autism spectrum disorder tend to have more deficits in adaptive behavior than we would expect. Evaluation of communication, that being one of the core parts. Assessment of autism symptoms. So a standardized assessment looking at symptoms of autism. Many of you have probably heard of the ADOS, Autism Diagnostic Observation Schedule, and that's a classic. There are other assessments out there that are also standardized and validated. And finally, medical evaluation. See if there is a genetic disorder. Is there something else that needs to be worked up, considered? If there is a genetic syndrome, if there's something else going on, do we need referral to other specialists? And now I am going to hand it over to Amy, who's going to tell us what we can do to help.
Thank you, Dr. Anderson. What great information. That was wonderful. Well, you can go to the next slide. The first thing that I would suggest that you can do to help someone you love who has autism is to give us a call at the one of the Alabama Regional Autism Network locations. As you can see from the map here, the regional autism networks cover the entire state. So no matter where you are right now listening to this in Alabama, you have a regional autism network that you can call for help. I'll just tell you real quickly, all of the networks are located, they're housed in the various universities across the state. So the yellow part of the map up in North Alabama Their regional autism network is based at the University of Alabama at Huntsville. The green area is covered by UAB. The huge red area is covered by Auburn University. The blue area is University of South Alabama, and the purple area, region 2, is covered by the University of Alabama. And each one of us at these centers are so excited to hear from you and to help you whenever possible. The reason that the regional autism networks were created has a lot to do with how quickly the incidence of autism was rising, and how Alabama recognized we weren't really keeping up very well with the needs of people in Alabama. And so the regional autism networks were created to help meet those needs in a number of ways. And you can go to the next slide, please, Dr. Anderson. So what do the regional autism networks do? First and foremost, and above everything else, we are committed to providing assistance to individuals with autism and the people who love and care for them in any way that we can. And what that looks like is helping you guys find the resources that are available to you, answering your questions, giving you explanations of what kinds of systems might be in place to help you get to services. So we answer the phones, we answer the emails, and we never quite know for sure what the question is going to be when we answer those phones. We've talked a lot about children, but we serve people with autism across the lifespan. So it could be anything from, I think my child has autism, what should I do? Get a lot of, I think my husband has autism, what should I do? Also problems or situations with school, trying to get services through school. How can I do that? What are good dentists in my area for treating children who have autism? Just a wide variety of things that we get asked. And so what each of us do in our regions is we keep very extensive resource lists, and we keep up with we try to keep them as current as possible. And so we know who is seeing what kind of family, what kind of the services, how to access those services. So we help with those type issues. Okay, Dr. Anderson, you can go to the next one. We also offer assistance to other care providers in the community that we serve. So if an educator is looking for specific resources, or a physician or a social worker or whomever might be needing help with the people they serve with autism, we are ready to help them too. That's a really a nice thing when we have another service provider call us for information, because we know that that really extends our reach. If we can help another service provider, we know that they're going to be able to help everybody that they help. So we really like doing that as well. And the next slide, please. We also help put together and organize professional trainings and parent trainings, public education, like the one that you guys are attending right now. And we really like to partner with other agencies and entities like wonderful APEC, who we absolutely love working with, and HTRAN, that's also helping us here. But one thing that we try to remind ourselves to do is to listen to what you guys need. I'm going to admit that as professionals, sometimes we're bad about trying to tell you guys what you need, because we're the so-called experts. At the Regional Autism Network, we really try to listen to what you are telling us you need. Teresa mentioned at the beginning of this presentation that it came about because there was a parent who reached out to her and asked for it. So I would encourage and invite you guys to let us know, let Teresa know, let your other service providers know what kinds of trainings you're interested in. And the staff of the regional autism networks may not themselves be experts in that area, but we can help locate people who can do those trainings. So please don't hesitate to let us know about that. And next slide, please. But here's the thing about the statewide regional autism networks that is, these are the best thing that we have to offer, in my opinion. And these are our autism family navigators. There are 4 of them across the state, and I'm going to introduce them on the slide from starting at the top left. Gwen Brown serves out of the Regional Autism Network at UAB. Tammy Barkey in the middle up there is at the University of Alabama. 99% of you on this call know the next person, Maria Gutierrez, who wears many hats in the state, and one of them is as the Autism Family Navigator out of Auburn University. And down at the bottom with her beautiful family is Cherish Fletcher, who is the Autism Family Navigator from the University of South Alabama. These ladies are wonderful, wonderful resources for you. All of them are, in this case, moms of young people with autism. And they have walked the road that you are walking. They have the experiences and the wisdom that has come from the challenges and the joys of raising a youngster with autism. And they are all available to answer phone calls, give advice, give guidance, and a lot of times just listen. So we would really love for you guys to reach out to us, and we can get you connected to one of these family navigators if you would like. Okay, Dr. Anderson, next slide. I want to go briefly through some other resources. I've picked ones that are available to you no matter where you are in the state. And most of you are probably aware of the Alabama Early Intervention System, which is the state's system of care for children that have developmental disabilities, not just autism, but including autism, from birth to 3. And that 800 number on there is the first call that a family should make if they have some concerns about the development of their child. But what I really am excited to tell you about is over the last couple of years, Alabama Early Intervention has been making a very focused effort to train their providers in recognizing signs of autism in very young children, and of how to address some of those early signs through the techniques that they use in the homes. There's been a real concerted effort led by a psychologist at UAB and a speech pathologist at the University of Alabama to train these professionals that go into the homes to use specific techniques in the homes with children, and also to serve as a resource for other early intervention providers in their region. So if you are a part of the early intervention system and you have some autism concerns, mention it to the service coordinator or the special instructor, and let them know that you would like for one of the people who have been specially trained to maybe look in on your case and see what's going on. Okay, next slide, please. Another great service that's relatively new and still developing in our state is through the Alabama Department of Mental Health, and it's specifically for individuals who are covered by Medicaid and have a diagnosis of autism. This service is provided statewide right now. Again, I've put an 800 number on this slide that you can call to get more information and to get the process started of applying for these services. They are focused on individuals with autism who need some additional support, particularly behavioral support in their home or in the community to help them function better and have better lifestyles in the community. There's a lot to this program, and it could probably support its own presentation, but that 800 number there will get you started on finding out more about it. The next slide, please. The Autism Society of Alabama is our state's main advocacy group for people with autism, and they do a lot of great things. I did want to just highlight several things that they're working on right now. Safety initiatives are a big part of the mission of the Autism Society of Alabama. And one of the things they're doing is offering a special autism specific training for first responders across the state. This is to help first responders to understand, recognize and understand individuals with autism, so that should they respond to an emergency and the person who is they are responding to has autism, they can manage the situation with greater understanding and make it a better experience for the person. So that's one of the things that they offer. The Autism Society also has a camp every fall for families called Camp Frog. And they offer autism care binders, which you can apply for online, and they'll send it to you in the mail. It is a binder, and it's already pre-organized for you to help you keep all of your records and things straight in case, so that you can have everything you need at hand. It's a really good resource. Also, twice a year, the Autism Society offers family grants in the fall and again in the spring. And right now is when that grant application process is taking place. So if you get online at the Autism Society of Alabama and apply for a family grant, you can see more information about what those grants are. You can use them for. I know paying co-pays on therapy is one of the things that it can be used for. They're awarded by lottery. So, and I think you can only apply, they award them twice a year. I think you can, each family that wins one can only apply once a year, but those funds are obviously very helpful and very welcome, I'm sure. All right, next slide, please. This is one of my favorite resources on the planet. I'm a Sesame Street fan from back when I had little babies. And Sesame Street, many of you know, have added a new character to their group. Her name is Julia, and this is a picture of Julia. And they also have a whole autism initiative that you can access by going to this website that I've got listed on this slide. Everything on here from storybooks about that include the character with autism and help explain characteristics of autism to maybe their friends or their peers. There are videos on there, coloring and activity pages, and just more things than I can even begin to describe to you. It's a fabulous resource that I love, and everything is free of charge on there. Next slide, please. This one is not quite as well known probably, but the Autism Navigator is an excellent project that it comes out of Florida State University, and but is available across the country. I think across other countries as well. You go to this website, www.autismnavigator.com, and you will be asked to register and create a password. The majority of the materials on there for families are without charge. I will tell you there are a couple of workshops and things that they do charge for, but most of the content is free of charge. There is a part of this website that's called Baby Navigator. And when families, when they first find out they're expecting, can register for Baby Navigator. And then as their child is born for the first 2 years of life, they'll receive little online screenings so that they can self-screen the social development and early communication development of their baby. And if there are any red flags, it gives them some suggestions of what next steps would be. It's a really nice tool for parents of very young children. Then the Autism Navigator portion of this website is more videos and training modules for families to help them as they navigate the early days of finding out that their child has autism. One really strong feature on there is a video glossary. So you may hear terms thrown around that you're not quite sure what that means. What is echolalia? What is stimming? And it has a lot of videos that demonstrate what those behaviors are. So again, another really good resource. Okay, Dr. Anderson. Also, again, I want to remind you that autism does grow up. So we put all this emphasis on very young children, but we do have resources available as children grow into the next stage and move toward adulthood. And the one I wanted to just highlight and remind you of here is the state vocational rehabilitation service, which comes under the Alabama Department of Rehabilitation Services. The state office intake number is listed here. And what you need to know as your child gets older is that every school in the state of Alabama has a designated vocational rehabilitation counselor. And when your child turns about 15, that's the time to ask your school to hook you up with the vocational rehab counselor. That counselor is not a school employee, it's a Department of Rehab Services employee, but works with the school and can be invited to the IEP meeting as early as the age of 15 or 16, and to begin to talk about a plan for transitioning out of school and into young adulthood. And these vocational rehabilitation counselors are going to be a great resource for you as the school services begin to end and it's time to look for something else. So that is just one thing I wanted to make sure that everybody is aware of. Okay, Dr. Anderson. Again, I think a lot of you on here are not only familiar with this, but I think this organization is why many of you are here. But I want to highlight the Alabama Hispanic Training and Resource Advocacy Network, HTRAN. And there's that very familiar name, Maria Gutierrez. She's a great resource for those of you who speak Spanish and need some assistance in navigating these systems that we talk about, not just for individuals with autism, but with other disabilities. So please give Maria a call if you have questions or have need further information. Maria, if you'd like to, you might want to say more about this than I have.
Thank you, Miss Amy. I just want to invite parents and professionals to continue making referrals to us, and we will be assisting them as much as we can. And there are always resources that parents might not be familiar. You know, for example, the Yellow Dot program, Project Lifesaver, just to name a few. So we want to make sure that the parents are aware of those resources and put them in touch with them. So please feel welcome to give us a call and let us know what are your needs, and we'll be happy to assist you. I know that Dr. Hill and Dr. Drew are joining us, so if they would like to add something, they are more than welcome.
I think you said it all, Maria. Thank you.
Always thank you, Maria. We appreciate all the work that you do, and especially helping our families gain language access. And we're happy to support families as we can. And we have our presentations that we run 2 a month. And so we're happy to support any speakers who want to come speak to the folks we work with, professionals out there. And then for families, I saw some familiar names when I looked at the participants. So happy to have y'all here as well.
And Teresa, I think that is it for us.
Dr. Anderson, I have sent the questions that were coming through the chat box directly to you. So I don't know if Teresa would like to add anything else, or if they want to go ahead and start responding to questions.
Teresa, did you want to add something? Well, this is information about APEC, contact information, etc. I am going to unshare my screen so I can see the questions.
Oh, I'm sorry, I was muted.
Okay.
I'm just a talking. Sorry. I'm just talking, giving my little spiel. I'm so sorry. I'm sorry. So yes, so you all shared great quality information, but if there's a parent or a professional here and their student or their young person does not receive educational services and they feel that they need to receive those services, just know that you can request that an evaluation through your local school system. And I would do that in writing. And then with that, the child will have an educational evaluation through their local school system, and that will start the process going. We at APEC can help you with that process if you need help. And you can contact us directly at our information. Here's our information here. I'm not going to prolong the training, but this is our information here. Also, I want everyone to know our annual conference is coming. We have some great speakers coming to our training. Some of our top, this training was awesome. And I want to thank the ladies for that. They did a wonderful, wonderful job. But I put the link for the registration for our annual conference in the chat. And we're going to have topics like traumatic brain injury. Early intervention will be speaking for us. Ms. Felicia Carswell, she will be speaking and presenting at our conference. We're going to have a speaker who's going to speak on ADHD in girls and how it presents. Of course, H-Tran is going to speak with us. We're going to talk about mental health, your mental health matters. We're going to talk about guardianship and conservatorship. But we're also going to have a very special speaker. His name is Kobe Spangler. And he is a young man who advocated for himself. And now he is off in college at I think the University of Alabama. He has an impressive story. And that session is going to be geared towards our young people, as well as our parents as well. But that's going to be our evening session on the 19th. But our conference starts on May 18th. And what I want to encourage everyone to come to our conference. It's virtual and of course of no cost, and share the information with others. And again, the link is in the chat. Okay. And so if you, Maria, you can read the questions now.
Okay. Let me go back all the way back to the chat box.
I'm sorry.
No, that's fine. Not a problem. So the first question is, can you explain what it means, the levels of severity when we get a diagnosis of autism level 2?
Um, and so the levels of severity are how much support the individual needs in different situations. Level 1 is requiring support, but not a lot of support. Level 1 for your social communication and interaction, without supports, the person has deficits in social communication, some noticeable impairments, trouble sometimes initiating interactions, clear examples of atypical, unsuccessful responses. A level 2 in the social communication and interaction, more marked deficits in social communication skills, limited initiation without assistance, reduced abnormal responses, and level 3 requiring very substantial supports, severe deficits in verbal and nonverbal social communication. So very limited communication interaction. On the restricted repetitive behavior side, level 1 requiring support, you have inflexibility that causes significant interference with functioning in at least one setting, trouble switching between activities, problems organizing, planning, and so might need extra help for that. Level 2, requiring substantial support, trouble coping with change, other restricted repetitive behaviors, or they're frequently enough to be obvious to a casual observer, your man on the street, and interfere with functioning in more than one setting. And then requiring very substantial support. The inflexibility is very disabling, requiring, again, very substantial support, a lot of assistance in order to get through daily activities.
The next question is it true autism presents differently in girls? Where can I find more information, as the school said my daughter is too social to be autistic?
Yes, it often does present differently in girls. As we know, girls in general, typically developing girls in general, tend to be more socially skilled than boys. The same is true in girls with autism spectrum disorder. That being said, this isn't true for every girl, but many tend to get missed because of that. And there are a number of resources. I think that Amy may have some.
I do, and if whoever was asking that question would like to send me an email, I can, or call me next week, or how can I get their email? I can send them some articles that I have on girls with autism, kind of get them started.
Thank you, Miss Amy. The next question, what about when a child keeps clearing his throat and the doctor think it's just a tick, but I think he is on the spectrum? Can people with ASD have tics?
Absolutely. Yeah, a tick in by itself isn't diagnostic, but we often have tics and other stereotypies with autism spectrum disorder. So yeah, this is one of those circumstances where it certainly could be both easily.
The next question is, in your opinion, children with a diagnosis of autism should be referred for genetic testing to rule out other conditions?
In some cases, if there's, I tend to do it with almost every child that I see, just because I can. Um, but there are some indications that would make me really want to go in more depth. If there is a strong family history of autism, I think that's certainly an indication. If the child has other physical differences, physical anomalies, if their facial features look different, these all might be things that would increase my recommendation to get genetic testing.
I guess this is a follow-up question. What is the criteria to request genetic testing, and how can we advocate with a pediatrician?
So with genetic testing, it is not always covered by insurance, and it can be very expensive. And that is often a reason that a pediatrician would not want to order it, not wanting to give you those thousands of dollars of expenses. The different characteristics I mentioned, again, would increase my desire. And there are different recommendations of genetic testing that have been put out by different organizations, including the American Academy of Pediatrics, the Academy of Neurology, I forget exactly what their name is, but there are specific recommendations. So you may want to ask, well, what are the recommendations of the American Academy of Pediatrics?
The next question, can younger children be diagnosed with depression? I am talking about as young as a 5-year-old.
With a 5-year-old, I would be very careful with that. There are a lot of things that can look like depression, but yes, we can certainly see some of the symptoms of depression very early on. We can see some withdrawal, ongoing sadness, but there are a lot of different things that can look like depression. And I would say if you're specifically thinking of someone, I would recommend going and getting further evaluation for that.
The next question, my child has a lot of sensory issues that get in the way of interacting appropriately with others. My concern is the school does not want to conduct an evaluation. My child chews his shirt and everything he can get his hands on. Should I ask the pediatrician for a referral to do an OT evaluation?
Again, there's a question of insurance coverage. So in many cases, many insurers will not cover occupational therapy if it's specifically for sensory processing. If it's fine motor, they will, and even some insurers will balk at that for occupational therapy. I would like to hear what APEC has to say about this, actually.
I cannot make a determination on what a doctor will or will not do because I'm not a medical professional, but you can always ask that question.
Yeah.
You can ask the school to make a evaluation in that matter, but I cannot say what a doctor himself will or will.
I was specifically referring to asking the school.
Oh yeah, you could ask this. Yeah, you can ask the school to evaluate for that. Yes. Now, whether they'll do it or not, it's a different story. But yes, if it is interfering with the educational process, or if correcting that behavior will promote education or help promote the educational process, then you can definitely ask for an evaluation in that.
The next question is, at what age is it more recommended to introduce an autistic child to a sport?
It depends on the child and the child's level of functioning. You know, I have some patients who begin tumbling gymnastics at preschool age. But it all depends on the child. If the child is showing no interest in the environment, you know, that child probably isn't going to be real interested in participating in any kind of sport. If there's a follow-up question, some clarification, I'd be glad to elaborate further.
The next question is, it says, did I understand correctly when you said a primary care physician could diagnose autism? My child is on the waiting list to be seen at Glenwood, but the waiting time is 12 months and we only have an educational eligibility.
So there's nothing that says that a primary care physician cannot diagnose. That being said, many primary care physicians are not comfortable, and I respect that. They, especially if it's someone who isn't a clear-cut case, they might prefer to have someone else do a much more in-depth evaluation than they can do. In some cases, some primary care physicians just don't feel that they know enough to say yay or nay. So yes, a primary care physician can, but whether your primary care physician feels comfortable doing it is another question.
The next question probably is for Miss Amy. Do I need to be referred by a doctor to the regional autism network?
No, you do not. We do not need any kind of referral. You just pick up the phone and call us or send us an email. We don't really, we don't enroll people as our clients. You don't even, you don't have to prove a diagnosis or anything like that to the Regional Autism Network. We're just here to help whomever needs help.
Apex sends people to RAN all the time.
There are a couple of comments. This has been an excellent educational training. Gwen and Miss Maria are amazing. There's another question. Will the PowerPoint slides will be shared with the attendees? Yes. And every person that registered to attend this presentation will be receiving a copy of the PowerPoint and the recording link when it is ready. We also are working on the process to translate the PowerPoint into Spanish and Korean. So please be patient, but everything will be shared with you guys. The next question, oh, actually it's a comment. I am grateful for you guys hosting this presentation at a time where parents can attend. Most of the workshops are during the day. Thank you to Dr. Anderson and all the other professionals. Thank you also for providing the interpreters. Great information and resources. I will share those with the families we serve at our agency. Thank you. Another question is, does VR cost money?
VR, vocational rehab does not. It is a state-funded service.
Okay. Another comment. Thank you very much for the informative presentation. Love the neurological explanation regarding autism. Had never seen it explained like that. Thank you for all the interpreters. And what advice do you have for dealing with behavioral and aggression?
I'm not sure exactly what you mean by behavioral integration.
I guess it's a question that somebody has regarding their child having behavioral issues and aggression, being aggressive.
Oh, and aggression. Okay. So that's a big question. Behavior issues and aggression are a big thing. I have different techniques work in different situations and at different ages. And I'm trying to think. I believe Autism Speaks has a lot of resources on that that you can get to for free. I think, if I'm not mistaken, it's autismspeaks.org. And I would recommend going there and looking through, because they have general behavioral information, and I know they have information about specific behaviors.
The next question is, what study does my child needs to have administered to determine the degree of autism she has? And at what age should that degree be determined?
So I think this is asking about severity levels. There's no one specific test, but looking at adaptive functioning, and there are adaptive behavior scales, but also your autism symptom specific evaluations. I think it's most useful as we're getting towards adolescence, that, a preschooler, not so much. But when we're starting to think about, okay, what's our whole life plan? It may be more useful to look at the severity specifiers.
And the last question is, how could I convince my Alabama school district to offer parent training to special needs families? It seems they do not want parents to gain knowledge to become better advocates.
I think I will defer that to Teresa or Amy if one of you has a good suggestion for dealing with the school system.
Well, here at APEC, we really like to try to build relationships between the schools and the families. And, parents want to know information, and sometimes they don't know what they don't know, and they ask for these trainings. And we can approach the school systems and say, hey, can we come in and, do a presentation for you? If they don't approach us, and we're actively doing that, and we try to bridge that gap that way. But we cannot force our way in, and we don't want to do that. But we are all about making happy, well-rounded young people, because that is our future. And so that's the way we want to present ourselves. And so if you are a parent or a professional and you approach it from that manner, and you say you want RAN or HRAN or APEC to come in and present a training to your parents or professionals, and just for knowledge sake, hopefully the leadership in that building or that county would be open to that. Is not going to cost them anything other than offering a space. to do that. I don't know. Anyone
Yeah,
else?
Teresa, I mean, and I'm going to take a stab at this, and you tell me if I'm off base, but I would suggest if you're feeling some resistance from the school system itself to do this, it's not necessary to go through them to train parents. APEC in particular does so many trainings and is very receptive to specifically what kind of trainings you want. So I would suggest you just start with Teresa's organization, APEC, and let her know what kinds of trainings you're interested in, and see if she can, help get one together like this one tonight. If this is the format that works for a lot of families, I think one good thing that came out of COVID was we all learned to be pretty good at these crazy kind of blind presentations like we're doing tonight, but you can do them at times like this, and you can do them to reach the whole state. And APEC is absolutely, I think that would be my first stop to ask for that. And then she can call in the other agencies or, the people that are experts on specific topics, about disabilities.
At APEC, we go to churches, we go to community centers, sororities and fraternities, whatever groups or organizations want the information and can use the information, we're willing to present that information. So, just contact us and let us know. Just spread the word that we're out here, and we're willing to help if we can.
Well, those were all the questions that they were on the chat box. Teresa, Dr. Anderson, and Miss Amy, I don't know if there's anything that you guys would like to add.
I would like to thank you and Teresa and Amy for everything you've done this evening.
And the wonderful interpreters, all of you.
Yes.
Amazing.
Yes, thank you all. It has been wonderful. And I encourage everyone to sign up to attend our conference, our annual conference on the 18th and the 19th. It's going to be great. We've got some great speakers coming, some great information. So please join us, and also tell your friends. And it's via Zoom as well, via Zoom. So please join us for that. And if that is all, we're going to close. Anyone else have any final words?
I just want to add that I appreciate so much that collaboration between APEC, RAN, and all the other agencies, so that we could have this presentation. So thank you so very much to Dr. Anderson for taking the time to develop this amazing PowerPoint with this very important information for our parents and professionals, and be on the lookout for the emails to come out with more opportunities for your parents and the families that you serve, for them to continue learning. So thank you so very much. And if there's yes, Teresa?
One last thing. If this training was useful, informative, and of high quality, if you would just say yes in the chat box, that would be great, or give us a thumbs up, because I cannot do a poll on this one. That would be great. And then we can end it on that note.
Well, thank you again, and thank you to our interpreters, and I hope that everybody has a wonderful weekend.
All righty. Thank you, everyone. Thank you, ladies. Dr. Hill, if you're still out there, all of our partners.